Welcome everyone to this morning's San Antonio Breast Cancer Symposium special session on HER2-low breast cancer. My name is Poppy C. Ziopikou. I am the Director of Breast Pathology at Northwestern and the Chair for Pathology Issues at the San Antonio Breast Cancer Symposium. Together with my co-chair of this session, Dr. Adam Bursky from the University of Pittsburgh, we welcome here today a distinguished panel of speakers who for the next couple of hours will be discussing with us the challenging multidisciplinary topic of HER2-low breast cancer. We also have a group of outstanding and highly impactful studies associated with this session. I encourage all of you to seek them out and also talk to the investigators about the specific findings. So until very recently, in these high-profile sessions at the San Antonio meeting or other similar meetings on HER2 breast cancer, we were focusing on the HER2-positive cases. However, after the New England Journal of Medicine publication of the Destiny Breast 04 study this July, and many other excellent studies along the same lines, our attention now is focusing on the diagnosis and treatment of another large subgroup of HER2 breast carcinomas, the HER2-low. Our challenge is twofold. On one hand, we need to accurately, reliably, and reproducibly identify HER2-low breast cancer cases in the pathology laboratory. And on the other hand, we need to understand the best way to offer the most effective treatment modalities to our HER2-low breast patients. We have three outstanding presentations this morning on this exciting multidisciplinary topic. We will start our discussion by first focusing on the complex pathology issues of HER2-low breast cancer, how we accurately diagnose these cases, and what are some new developments that can help us with our assays and interpretation. Dr. David Rimm will discuss these pathology issues. Dr. Rimm is professor of pathology in the departments of pathology and medicine at Yale University School of Medicine. He is the director of the Yale Pathology Tissue Services and the director of the Laboratory for Quantitative Diagnostics in Anatomic Pathology. His research laboratory group focuses on quantitative pathology and the use of new high-plex methods for biomarker discovery. He's also interested in how innovative research assays translate into the clinic and the standardization of those assays for CLIA laboratories. He also serves on the CAP Immunohistochemistry Committee and multiple scientific boards for biotech and pharma. David?
Thank you, Poppy. I'd like to start by thanking the organizers to give a very unusual opportunity for a pathologist to speak to thousands of oncologists and the opportunity to try to clarify this. However, I would also like to qualify this as not being a standard pathologist, but rather a progressive pathologist perspective on HER2-low. Okay. Can't seem to get the slides to advance. There we go, thank you. These are my disclosures. This is what we're going to talk about for the next 27 minutes or so. First, I'll give you the pathologist perspective, including trying to summarize the pathologist posters that are right outside the door, and I encourage you all to spend some time on those. And then, is low HER2 a separate entity? I'll look at some historical data, some new data that's unpublished but we'll publish in January, and then a proposed next step, a new quantitative high-sensitivity HER2 assay. This is the guidelines that we're all very familiar with and were very useful until just recently, and that is that when we had a HER2 1 or 0, we called it negative and patient didn't get trastuzumab or similar targeted therapies. And their HER2 IHC 3+, they were positive and got drug. And for HER2 2+, we had an equivocal diagnosis, but then we had an adjudicating test, in this case FISH, fluorescence in situ hybridization. This is now what we're faced with in this nice recent review. Instead of just it being a cut point between two positive and negative, we now have a HER2 low category that we have to figure out how to work with. And as you can see in this paper, there's HER2 zeros, which have been separated from HER2 lows and HER2 positive. There are 3 posters at this meeting that discuss this process. One from Elise Pratt, who notes that there's a 77% agreement between historical and central HER2 low status using the Ventana pathway assay. One from Giuseppe Viale, Bepi, and his group, saying that overall percentage agreement between rescored and historical HER2 scores was 82%, 81.2%, numerically greater than HER2 low, than IHC 0. And finally, Joe Rusoff has a poster that showed that overall score concordance of a new category of HER2 low was above 80% overall rater agreement benchmark for both 4B5 and the Hercept test, higher than previously reported by Fernandez et al., JAMA Oncology 22, which is the reason I'm here in front of you. Fernandez et al. is a work from our lab. This data demonstrates pathologist ability to achieve an acceptable level of accuracy for HER2 low patients. This is a direct quote from the poster. I would argue 80% is not an acceptable level for patients. So what is Fernandez et al. Showing? What we found is quite different. When we looked at 18 pathologists from 15 different institutions and did not tell them that they were going to be adjudicating 0 from 1, but rather assumed that they would do that to the best of their ability, we found that there was a discordance of 41% in distinguishing 0 from 1 or higher, and a discordance of only 10% between 3 and not 3. So 90% of the time, we can get it right, whether it's amplified or not amplified, or whether it's 3+ or not 3+. But 60% of we only get it right 60% of the time, so even 20% less than suggested by the previous posters at this meeting. So what if we looked at actually a little more closely at that data? Here's all 18 pathologists, and you can see the most liberal pathologist calls 40% HER2 0, and the most conservative pathologist calls only 20% HER2 0. The rest of them are shown here, and you can see also very little difference in the 3+ versus 2+. So how are we going to analyze this? How many observers do we need? Do we need just 1 or 2 or 3 or 4 or 6 or 8? There's 21,000 pathologists in the US and 100,000 pathologists in the world. So I would argue that we ought to come up with a method to figure out the observers needed for evaluation of a subjective test or an honest plot. And we'll do this by simply mapping the overall percent agreement versus the number of pathologists in the group of readers. This is shown here, and to explain it, if you look at a quartet of pathologists, it ranges between 90% and 98%. Each circle is a random quartet of pathologists, and here's trios, and here's quintets of pathologists. And as you can see, we're pretty darn good at determining estrogen receptor positive from estrogen receptor negative. How do we do for HER2? Well, for HER3, for 3+ versus not 3+, as we pointed out already, we do really well. But for 0 versus not 0, you can see a very wide range where even 2 pathologists only agree 50% of the time for this pair of pathologists, while as this pair of pathologists, which may have been Bepi Viale and others, have a very high percentage, 95 or 98% agreement. And so if you plot every possible combination, you'd have over 18 billion combinations and couldn't plot them. But instead look at just a randomly selected 100 combinations, you can see that while we are very good as pathologists at separating HER2 3+ versus not 3+, we don't do very well with 0 versus not 0, plateauing at around 8 or 10 pathologists and ending up at around 30% compared to 1+ versus not 1+, which goes down to an overall percent agreement of 0% at 10 readers. So this will all be published, and I'd like to thank George Netto, the editor of Modern Pathology, for allowing me to show this a month before it's published in Modern Pathology. Can you do this? So the key consideration here is that all data published to date and presented at this meeting depends on a flawed premise. That is that historically read IHC can tell IHC 1s from IHC 0s. I would argue that as we think about whether HER2 low is a separate entity or not over the period of the next hour, we should remember that anyone that uses IHC 0 versus IHC 1 to dichotomize their data is subject to error, and probably we need further work in order to figure this out. The honest plots are available publicly, and it's published in Statistics and Medicine, and this paper by Reisenbichler et al. Was the first publication of about a year ago or so in Modern Pathology. And if you're facile with the computer, you can go on GitHub and have your biostatistician download everything you need to do your own honest plots. So next, let's look at, is HER2 a separate entity? And this is really the topic of the session, and now the pathologist's perspective on that. So first I want to look at historical data, and I would argue that rather than looking at 1 plus versus 0 by IHC, we should look at outcome. And the first to look at outcome was Sergei Koscielny back in 1998, where he noticed that low expression showed, and they had only 10 patients in this group, had a relatively low expression. Normal expression, this would have been, low expression would have been the equivalent of HER2 0. Normal expression, which means the levels that are present in normal breast ducts, would have had about a 90% 38-month 3 metastasis survival, and then high expression did worse. So in fact, there was a U-shaped relationship with outcome, which to me suggests that HER2 0 may be a separate entity. Here's another quick example where we see cell lines that are amplified and cell lines that are not amplified. And in the not amplified cell lines, there are some cell lines that truly express no HER2, and there's other cell lines that express low amounts of HER2. Keep this in mind, since this same plot will be shown later to show how you need to assay these differently in order to stratify amplified cases from non-amplified cases. The third piece of evidence that we have is work by Dan Hayes' group and our group combined to look at 9313, a trial that was done by SWOG, which shows this U-shaped relationship. The bottom two bars are the lowest 10% and the highest 10% measured quantitatively with the Aqua technology back in 2011. And you can see that the middle group, the HER2 low, which would be considered now the HER2 lows, do better than either the HER2 zeros or the HER2 highs. And this plot generated by Bill Barlow shows us the relationship between the log of HER2 amounts and the hazard ratio, whereas there's a high hazard ratio for the zeros and a high hazard ratio for prognosis for high HER2, and the HER2 lows actually suggest possibly a third category of HER2 expression. What about new data, the abstracts at this meeting? And I'll try to summarize these for you, although I still encourage you to go out and take a look at those posters which are outside the door. There were 7 posters that support the idea of a separate entity, and they are from Karsten Dendrick. Karsten Dendrick said 60% were HER2 low and 40% were HER2 zero. A low status in the biopsy was significantly linked to improved disease-free survival. Rothschild and colleagues said we identified a difference in disease-free survival between HER2 negative and HER2 low. Raghavendra et al. Said in metastatic patients, HER2 low status was significantly associated with longer OS and disease-free compared to HER2 zero. Zadarin shows that in a multi-center Italian study, HER2 low status has independent negative prognostic value. Xiao et al. Says HER2 low breast cancer in East Asian populations show HER2 low breast cancer in the negative group was more likely to be molecularly distinct from HER2 in the HER2 zero group. Ahmed showed in a Tempest study, the multimodal real-world data reveals that HER2 low breast cancers are comprised of distinct molecular subtypes. And finally, Yam et al. Said gene expression analysis suggests that drivers of resistance to neoadjuvant therapy differ between HER2 low and HER2 zero. These are quotes from the posters that I wanted to share with you, supporting this fact that they're a separate entity. There's also quite a bit of support for them not being a separate entity, and these are the 4 posters that support them not being separate entities. The first from Dr. Spring showing that in multivariate analysis adjusting for treatment arm and other factors, HER2 low status was not associated with worse disease-free survival compared to HER2 zero. Bonsai and colleagues showed, with some exceptions, HER2 low breast cancer shared genomic features in its more classically defined subset of either hormone positive or hormone negative disease. And finally, Mara said HER2 low breast cancer seemed not to represent a distinct pathologic subtype at the genomic level. However, some differences identified and became more specific upon subclassification by IHC. And finally, Tarantino and colleagues said patients with HER2 low negative or HER2 negative metastatic breast cancer, the genomic landscape of HER2 low and HER2 zero did not differ significantly. So 4 posters against, 7 posters for. In summary, the historical quantitative data suggests HER2 low has a different prognosis than HER2 very low or zero, or HER2 high amplified. That's the historical data. 7 abstracts at this meeting show data suggesting HER2 low is a separate entity representing 8,700 patients, and 4 abstracts at this meeting show HER2 data suggesting HER2 low is not a separate entity in 17,000 patients. The pathologists claim an overall 80% inter-rater agreement with current assays, but probably doesn't accommodate for real-world performance where we have 20,000 or 100,000 pathologists reading these specimens. So what can we do about this? The last step is a proposal to you oncologists to request that we pathologists be more accurate. Isn't it time to be digital? I think it's time to be digital, and here's our proposal. So here's the Wolf et al. Guidelines from the ASCO CAP, and now we have a new challenge. We not only need to adjudicate the HER2 2 pluses, but we need to adjudicate the HER2 zeros. One way to do it would just be instead of precision medicine, use persuasion medicine, and go talk to your pathologists and tell them, call them all HER2 1 plus, please. And unfortunately, this is happening. So please, pathologists, call them as you see them. Don't be persuaded by a potential therapy. That's not precision medicine. But what I would propose is an orthogonal assay is needed, a FISH analog, if you will, that can tell us which patients truly have HER2 present and which patients truly do not have target present. And there's a number of labs working in this. I'll start with data from Carl Barrett at AstraZeneca, where they're working on where he shared this slide, working on a quantitative method that's based on the same assay that was used initially for HER2, that is the currently FDA-approved assay, where they measure the optical density of the HER2 expression on the membrane in the traditional DAB or 4B5 assay. And you can see there's quite a wide range, and in fact, in each IHC category, you can see a pretty broad range of quantitative scores. I would argue this is a good first step, but it's not quantitative enough. I would argue we need to actually give you digital information or actual numbers. And so if we think about how assays work, okay, I'm getting a little wonky on you here, but we need to know the limit of detection, the limit of quantification, and the limit of linearity, and then we should look at the assay in the correct linear range and not at the saturated range. And from that data, we can actually then use our college biochemistry tools to make a standard curve with cell lines where we know the absolute amount of protein present. And to do that, we need to be in the right dynamic range. To be in that linear range that I pointed out to you, we need to use cell lines with low levels of HER2 expression, not the amplifieds. This antibody concentration is equivalent to the current assay, and basically all of the interesting HER2 low cases or HER2 low cell lines are indistinguishable, whereas this assay, which is equivalent to the new assay we're bringing to you, and others are also pioneering, can segment the low or separate the low HER2 cell lines. Here's an example of that, and this is a cell line microarray that's currently available from Array Sciences. You can see that if you use the traditional current high HER2 assay, all the low cell lines look pretty much the same, but you really can very effectively tell the highs, these two, from the lows. If you use quite a bit more antibody and use this as a standardization array, now you can see we can segment the low cell lines and the highs are saturated. But we don't need an assay for high HER2. We have that already. What we really need a new assay is for low HER2. And so we actually converted those to attimoles per square millimeter and made a standard curve, just like we did for our Bradford assays in college biochemistry. And we can measure signal, in this case aquascore, but any other signal can be used, and make a standard from the amount of signal you get from your assay to how many attimoles per square millimeter you have of HER2 in your assay. I would argue that most oncologists would not accept a ordinal value for sodium or magnesium or potassium or glucose, and neither should you accept an ordinal value, 0, 1, 2, 3 for HER2. Let's try to get it to you in attimoles per square millimeter. This is measuring attimoles per square millimeter on a series of about 350 cases from Yale, but it was done on a TMA. But you can see from the coloring of the IHC scores in the upper right-hand corner, using the standard curve that I just pointed out to you, that many cases are above the limit of quantification, but below the limit of linearity, and these are the HER2 lows. And actually, there's only about 8 or 10% of the cases that are truly below the limit of quantification. In a second study, now recently underway in my lab, we looked at core biopsies, and this is averaging across an entire core biopsy of invasive breast cancer. And all the black cases were called IHC 0 by our our clinical CLIA lab. And you can see many of them are well above the limit of detection for HER2, and suggesting that many of these patients actually do have plenty of target and might be responsive to trastuzumab deruxtecan. Finally, we have published how to do this. We've already made this available, and it's pretty much, and we actually do it in our CLIA lab, the so-called QDAP lab, or Quantitative Diagnostics and Anatomic Pathology lab at Yale, can now return this data. And it's done on common machines. It's done on the Leica Bond stainer, which many labs have, and we're now transitions over from the legacy Aqua scanner to a RareSight scanner, so that we can now we can use this scan information to determine the attimoles per square millimeter in rare time based on mass spec determination of the attimoles per square millimeter of each cell line. So finally, to summarize, HER2 protein on slides can be measured in an analytic assay and expressed as attimoles per square millimeter. This assay is in the correct dynamic range. We are not weighing mice on a scale built for elephants, which is the analogy used for the current assay in an article in the European Journal of Cancer from Baez Navarro and some of the pathologists whose posters are outside the room. And so I think it's really important that we make the assay in the correct dynamic range. This assay that I just showed you is an LDT, a lab-developed test. We can and do provide limit of detection, limit of quantification, and attimoles per square millimeter for this analytic HER2 assay. We do not know the level of expression required for response to trastuzumab deruxtecan. So this is work that still needs to be done, and this assay is not FDA approved. Finally, the overall summary is that our current IHC for HER2 is not reproducible between pathologists, since it's not designed for low HER2 dynamic range. In fact, it makes it hard to conclusively determine if HER2 low is a separate entity if the IHC is used to stratify study groups. And finally, it is possible to measure HER2 protein expression in attimoles per square millimeter on tissue using standard curves. And this information or other data, including potentially rumored new IHC assays with correct dynamic range, lead me to a better understanding of HER2. And I would just comment on that. It's rumored that some large companies are building an IHC assay that pathologists can read instead of measure that will work in the low range. However, as I stand here as a progressive pathologist, I encourage you all to measure, not read HER2. Thank you. Apparently, we're going to have some time for questions. That's great.
I thought that the Q&A was going to be at the end for all speakers.
Okay. Looks like we have 3 minutes, so if anyone has questions, I'll be happy to take them.
Questions from the floor?
David, hey, how are you? Brad Turner from Rochester.
Hi, Brad.
Hey, how are you doing? So we are limited now, and one of the things that we're looking at is the core versus the excision, which with the limited abilities we have now, we're looking at that with IHC. But with this technique, do you think it would be valuable to look at core versus excision because of heterogeneity?
Well, as we saw in the last presentation by Dr. Bardia, it's going to be really important to be able to measure this on core biopsies since it's coming to the neoadjuvant setting. But even in the metastatic setting, I think it's really important to look at as much as you can, and the technology that we use can do as many fields of view as you want. In fact, the RareSight scanner can scan a whole slide in 4 minutes, so it's no longer, the technology which was limiting 20 years ago when you invented Aqua is no longer limiting. And in fact, in our lab, we're not using Aqua anymore. We're using open source QPath technology for these measurements. So it's now very publicly available and very possible to do these measurements.
We are going to continue with the Q&A in further detail at the end, but there are many people up, so let's take one or two more questions. How about microphone 4?
Hayes, University of Michigan. Very nice talk, Dr. Rimm. I was a little confused, though. For the new assay, are these antibody dependent? In other words, is it a different antibody than what people have been using for standard IHC? Or is it any antibody works as long as you put it into a quantitative assay?
So everyone has to make their own lab-developed test. In this particular lab-developed test, we used a cell signaling antibody, and it's not the same as 4B5. In fact, 4B5 is a challenging antibody to use in that range because it cross-reacts with HER4. So I suggest people use other antibodies than 4B5, which is the most commonly used antibody today in the U.S.
I think there's someone at microphone 1.
5.
Hi, Alicia Arnold from Augusta University. At our institution, we do reflex fish testing on all invasive breast cancer specimens, and in our patient subset, we've actually identified significant amount of patients who have been HER2 positive by fish with an IHC of 0 or 1+. So would there be any benefit to doing a fish on all these specimens to at least get a copy and ratio number on these HER2 lows and prove, how low they really are,
So
or
this
if
is-
they're actually HER2 positive?
This is kind of a bold statement, but I think if we did quantitative HER2 20 years ago, FISH wouldn't have been necessary. FISH was necessary because her IHC failed in the 2+. And so we needed to adjudicate the 2+. But in answer to your question, FISH is probably not necessary if you do quantitative HER2 in attomos per square millimeter.
Thank you.
All right, and one final question for Dr. Rimm from microphone 5, please.
Dr. Vogel, New York. Very interesting presentation. So the hard part, as you say, is always at the margins. Where do you make the cut point? Are you going to be able to get hold of the specimens from the study that defined the activity of trastuzumab deruxtecan in these HER2 low patients and valid and basically create your cut points by who responded and who did not? And you probably should adjudicate the response separate from the drug company, because the drug company wants to make responses in everybody. If they can get away with it, you need somebody to very carefully decide how much response is a response that the doctor would like to know about.
I agree with you 100%, Dr. Vogel, and I hope that we're able to stimulate some cooperative group to try such a thing, and we will happily make, to the extent we're able, to make this assay available so we can find out exactly the answer to that question. Thank you.
Thank you.
Thank you very much. And
David.
we also will have time for more questions for Dr. Rimm after the debate.